Okay, sir, it's working now.
So from again from beginning or what?
Last 10 minutes, sir.
Okay. Hello everybody once again. Actually, I started the discussion, but there was some technical glitches, so I'll restart and I'll make it bit brief. So today's discussion is how to approach a patient of ischemic stroke or hemorrhagic stroke. As you know, stroke is a very common entity in our day-to-day practice everywhere. And out of the stroke, basically we have two types of stroke: ischemic stroke and hemorrhagic stroke. Ischemic stroke is much more often seen, nearly 80%, and others are hemorrhagic stroke. And CVA or stroke is a leading cause of morbidity and mortality all over the world, especially in Europe and Asia. So even if the patient survives acute stroke, subsequently the patient may be left with significant physical disability because of stroke. So it is one of the leading causes of disability in adults all over the world. The mortality, the incidence and prevalence of stroke is not same in all the countries, and it does not remain same even if whatever it is today or whatever it was previously. In developed countries, the incidence is decreasing gradually because of better medical facilities available and better awareness about the risk factors and how to prevent the development of stroke. But in countries like India and other developing countries, because of insufficient medical facilities available and lack of awareness about the prevention of stroke, the incidence is relatively high. So the incidence, as I mentioned, is different in different countries. This difference in incidence and prevalence of stroke may be because of various regions. One may be socioeconomic factors, dietary differences may be there, lifestyle may be different in different countries. So these factors are responsible for different incidence and prevalence in different countries. So when it comes to stroke management, the important thing is that to have good outcome, we should start the treatment as early as possible, because not every hour but every minute counts after the development of stroke. Early the treatment is given, the better will be the outcome. So for this we require not only better training of the medical staff but also public awareness about how to identify early features of stroke, because the patient may be at home and he may not pay attention to the early manifestations of stroke. So if the public education is good and public awareness is good, then patient or family members can identify early features of suspected stroke, and then the patient can be taken to the nearest medical center. Then the outcome will be better. So whenever a patient has developed stroke or when there is any suspicion, patient should be shifted to the nearest hospital as early as possible to have a better outcome. Because if there is a delay, the treatment will get delayed and the outcome may not be as good. So for better treatment of patients with stroke, we require educational program not only for the medical team but also for the public, because all these people will play a role in initiation of early treatment and also for shifting the patient to the right medical center early. So we should provide good proper education to the emergency team in the hospital, and also the people who reach the patient in the periphery, like it may be ambulance staff, it may be paramedical staff, so they can also help the patient in the periphery before the patient is shifted to the hospital. And after the patient should be sent to the hospital as early as possible, then the outcome is likely to be better. Sometimes what happens, the patient has got some stroke problem, but the expertise or specialists are not available at every center. In that case, the telemedicine can help. The patient may be in the periphery, patient may be admitted there, but with the help of telemedicine, we can transmit the data of the patient's clinical profile to CT centers, and from there we can get the feedback how to manage the patient. and subsequently take decision what to do next. So telemedicine can help. And sometimes what happens, the radiology department may not be there at everywhere. If the department is there, the experts may not be available. In that case, we can take the brain imaging and transmit the data to center where the radiologists are available. So in this way, radiologists may be far away, but with the help of teleradiology can give opinion about the diagnosis, whether it is stroke or not, if it is stroke, whether it is ischemic or hemorrhagic. So telemedicine and teleradiology can help in the treatment of patients away from the city centers. So when a patient has got a stroke, the evaluation in the hospital should be carried out as early as possible, so that treatment can be initiated early for better outcome. And for this, you do not require all sorts of investigations. Limited blood investigations and brain imaging is sufficient to make the diagnosis and also start definitive treatment. You don't have to carry out all the metabolic profile or all the organ function tests before you start the treatment. Just few simple investigations are sufficient, and then you can start the treatment as per the stroke protocol of your hospital. And this stroke protocol should be in place well in advance, so that patient comes, so you know how to go about it quickly. If the protocol is not there, then every time patient comes, you will think what to do first and what to do next. If the protocol is already well established, with the moment patient comes, treatment can be started in a particular sequence without loss of time. So after quick complete evaluation, patient diagnosis should be made, and then decision has to be taken whether the patient is a candidate of ischemic stroke requiring fibrinolytic or thrombolytic therapy, because this thrombolytic therapy, if required, should be given as early as possible to have better outcome. So preferably the treatment with the thrombolytic therapy should be given within the first hour after patient reaches the hospital. The window period may be up to 4.5 hours, but we don't have to wait till that time. So these are the stroke rating can be done to find out how severe the ischemic stroke is. As I mentioned, limited laboratory evaluation is sufficient, like blood count, coagulogram, blood sugar, and then you can do the brain imaging to decide about ischemic or hemorrhagic stroke and further step out of the treatment. So this CT scan is sufficient to make the diagnosis of ischemic stroke. So CT scan, if the patient is evaluated in first few hours, may show normal brain tissue. The stroke may not be, the ischemic area may not be visible. Only thing which is visible may be that some hyperdense blood vessel. Like here if you see, it is right middle cerebral artery which looks very white or hyperdense. But on the other side it is not. So this hyperdense MCA is sufficient to make the diagnosis of thrombotic ischemic stroke, though the infarct area may not be visible in first few hours. So this is sufficient to make the diagnosis of ischemic stroke, and then we can take decision about the treatment. So MRI is always better compared to CT scan to make the diagnosis of acute stroke, because MRI will show ischemic area within few minutes after the onset of ischemia. Like if you see here, this is the area of ischemia because of as seen in MRI due to diffusion restriction. But the same patient, if evaluated with CT scan, this area may not look abnormal. So MRI will help in the early diagnosis of definitive ischemic stroke. CT angiography is not routinely required, but if you carry out, it will show which particular blood vessel is blocked and is causing the stroke, ischemic stroke. That will also help in case patient needs revascularization mechanically with the help of some catheter. So then CT angiography will be useful, otherwise routinely it is not required. So if you do CT angiography, if you see this is the right middle cerebral artery which is visible, but contrast has not entered the left middle cerebral artery. So it means it is blocked. So it gives definitely which particular artery is blocked. MRI will show the same features, but here blood clot will appear dark or hypointense. So this is basically suggestive of thrombus in the left middle cerebral artery. Other tests which can be done to make the diagnosis of ischemic stroke is the transcranial Doppler, but it is not as sensitive as CT angiography or MR angiography. So if you do the angiography, it will show, you can take the help of either conventional CT angiography or DSA, digital subtraction angiography. That also will show presence of occlusion of one or other artery causing stroke. So this is just to show that if you do CT scan in the early phase, first few hours, the CT scan may not show area of occlusion. But if you do MRI, it will show the area of infarction. But if you repeat the CT scan after several hours or 1 or 2 days, then the infarct zone will be visible. So here the importance of MRI showing ischemic changes within few minutes after onset of ischemia. But CT scan will only show that there is no bleed that may be sufficient to make the diagnosis of ischemic stroke based on clinical picture. So once the diagnosis of ischemic stroke has been made, then decision should be taken whether the patient is the right candidate for thrombolytic therapy or not. If there are no contraindications, then thrombolytic therapy should be started as early as possible. Though intravenously, it can be given up to 4.5 hours after the onset of stroke, but we don't have to wait till that time. So if you have done CT scan before the thrombolytic therapy, and if you show area of hypodensity, infarction has already well established, then giving thrombolytic therapy may be counterproductive. Because once the infarct zone is already well established, then there are more chances of hemorrhage. Then these people are not candidate for thrombolytic therapy. Secondly, if the area of infarct is very big, more than 1/3 area of the MCA territory, again chance of bleeding will be very high. So then you don't have to give thrombolytic therapy. So besides the definitive therapy with the help of antiplatelet drugs or thrombolytic therapy, we should take care of the metabolic or homeostasis of the patient. There should not be any organ failure. Like patient should not have hypoxia, patient should not have a hypotension, patient should not have arrhythmia or any dysglycemia. If these things are there, those things should be corrected as early as possible. Because if these things are there, there will be double harmful effect on the brain. One is because of the stroke, and second because of the metabolic abnormalities. So all these things should be corrected along with the definitive treatment for stroke. So in case a patient has got ischemic stroke and also has got hypertension, so should we treat hypertension? If the patient has got ischemic stroke and blood pressure is very high, we should lower it only if we are planning thrombolytic therapy. Okay, if we are planning thrombolytic therapy, then we should bring the BP down quickly within minutes to less than 185 to 110. If thrombolytic therapy is not contemplated, then we should not decrease the blood pressure acutely, otherwise there may be more harm to the brain. So as I mentioned, beside the treatment of stroke and metabolic profile of the patient, we should take care of what is happening to various functions of the body, whether it is a sensorium is abnormal or not, bulbar function is normal or not, oxygen saturation is okay or not. All these things we should evaluate and provide adequate treatment to the patient. As I mentioned, only when thrombolytic therapy is being planned for the patient, we should lower the BP quickly. Otherwise, do not lower the BP. So if the BP is high and thrombolytic therapy is not required for the patient, then we should keep the we should allow the BP to remain high up to 220 systolic or up to diastolic 120. If it is beyond that, then we should decrease it about 20% in 24 hours. If you decrease the BP quickly, it may cause more ischemic injury to the brain. And besides that, if there is any hypoglycemia, hypovolemia, etc., those abnormalities should also be corrected. So thrombolytic therapy, most of the time it is given intravenously, though it can be given intra-arterially also in selected individuals. So the window period for intravenous thrombolytic therapy is up to 4.5 hours after the onset of ischemia. So basic idea is that it should be given as early as possible, but up to 4.5 hours it can be given. So important thing that CT scan should not show very frank hypodense infarct area, very large area should not be there. Okay. Otherwise you can give. If the very large infarct area is there or very advanced infarct has already developed, then we should not give a thrombolytic therapy. So there are various thrombolytic agents available. Most of the time we use altiplase. Though tenecteplase is also available, but altiplase is used more often. But we should also be aware about the cost of the treatment, because one course of this altiplase may cost up to 80,000 rupees. So you have to see the economic profile of the patient also. As I mentioned earlier, the treatment, better is the possibility of good outcome. In case the patient has come to the hospital, as I mentioned, best outcome will be if the treatment with thrombolytic therapy is started early, but up to 4.5 hours you can be given. The best results will be seen in first 3 hours. So what are the contraindications or indications for thrombolytic therapy? So which patients should be given thrombolytic therapy and which should not be given, we should evaluate the patient. So if a patient has got a stroke and patient has reached within the window period and neurological deficit is not improving, then you should give the treatment. And neurological deficit should be significant. If there is a little bit minor abnormality, then thrombolytic therapy should not be given because it has got its own chances of complication. If the minor neurological deficit is, don't give. Okay. Then you should treat the patient more conservatively. At the same time, there should not be any contraindications, like any evidence of bleeding from any site in the body. It may be upper GI, it may be lower GI, it may be recent arterial puncture, etc., or recent surgery. So these are the conditions where thrombolytic therapy should not be given. Again, BP only when you are giving thrombolytic therapy should be lowered if it is high. Otherwise, if it is high and you are not giving thrombolytic therapy, do not decrease the BP quickly. If the patient had received anticoagulant in last 2 hours, again you have to be careful. Then it should not be, the coagulogram should be normal. Platelet count should be normal or at least should be 1 lakh plus. There should be no other metabolic abnormalities like hypoxia and hypoglycemia. That should be corrected quickly so that thrombolytic therapy can be given to the patient. But all the patients with the ischemic stroke cannot be given thrombolytic therapy up to 4.5 hours. There are some people who are more likely to have hemorrhagic complication after thrombolytic therapy. In those cases, thrombolytic therapy should be given only up to 3 hours. Beyond 3 hours, we should not give, especially those who are very elderly. Okay, or a patient who received anticoagulant recently, or the patient has got severe stroke. NIH score is more than 25. Okay, if the patient has got associated history of diabetes. So these are the patients where thrombolytic therapy should be given for 3 hours only, not beyond that. Otherwise, chance of complication will be very high. So commonest agent is the RTP or altiplase. Again, we should be familiar with the cost of the treatment. So this is just to show what are the chances of benefit or harm to the patient if you give thrombolytic therapy. So if you give thrombolytic therapy in the window period, then chances of benefits are there to nearly 32 patients. So nearly 13 patients will have significant outcome and another 19-20 will have some benefit. Okay, only 3% are likely to have complications. So if you look at the benefits and the complications, benefits are much more than complications. So whenever possible, if there is no contraindications, we should offer thrombolytic therapy to the patient with ischemic stroke. Sometimes what happens, the patient has come beyond 4.5 hours and it is a case of ischemic stroke with no contraindications for thrombolytic therapy. Then we can give thrombolytic therapy intra-arterially. So up to 6 hours you can give intra-arterial thrombolytic therapy. Beyond up to 4.5 hours you can give intravenous, and from 4.5 hours to 6 hours you can give intra-arterial. So in that case we have to go with the help of catheter, reach the site of block where the occlusion is there and administer the thrombolytic agent locally. So if the patient has come a bit late, up to 8 hours, you can help the patient with ischemic stroke with the help of mechanical revascularization. So there are different techniques are available. You can do thromboembolectomy, you can do suction thrombectomy, you can do angioplasty and deployment of a stent. So these are the different mechanical approaches available to establish revascularization where thrombolytic agents cannot be given or the patient has come a bit late. So this mechanical way of revascularization is effective up to 8 hours in the anterior circulation of the brain. In the posterior circulation, up to 12 hours or even 18 hours, endovascular or mechanical interventions can be offered to the patient depending upon the condition of the patient. So they are just to show you can go to the area of block and you can remove the clot by various techniques which I already mentioned. Should we give anticoagulant in patients with stroke? Routinely, anticoagulants are not required, should not be given to patients with ischemic stroke because chances of complications in the form of bleeding is more with anticoagulant as compared to no anticoagulant. and there are no benefits. Anticoagulants should be given to ischemic stroke patient only in selected individuals. Otherwise, no. So, what are the indications when anticoagulants should be given? If those indications are there, give, otherwise, don't give. Okay, so you should give anticoagulant to a ischemic stroke only if there is evidence of some embolism going to the cerebral circulation, like cardiogenic problem is there. Patient may be having some arrhythmia, maybe some clot in the left atrium, left ventricle, and that is causing embolization and stroke. Or there is dissection of the artery which is causing the stroke. Again, the anticoagulant will help. Or if it is a crescendo type of progressive stroke, patient had some neurological deficit, after that is gradually worsening, again anticoagulant will help. Or there is occlusion of the basilar artery. And if the patient has got some other reason for need for anticoagulant, like patient has got well established, well known, previously known hypercoagulable state, or if you want to, patient has got cortical sinus thrombosis, then you should give anticoagulant. Otherwise, routinely anticoagulants are not given to patient with ischemic stroke. Other group of drugs which are given in the treatment of ischemic stroke, the antiplatelet. Every individual with ischemic stroke will receive antiplatelets. Depending upon indication, contraindications, you can use one or other. Most of the time, it is the aspirin which is given for treatment of ischemic stroke, but it is given only to those individuals who have already developed stroke. It is not given as primary prevention, which means if the patient never had a stroke, you don't have to give aspirin. In case of coronary artery disease, you can give aspirin even if there is no previous history of MI. But in case of stroke, aspirin is given only when patient had stroke previously. So it is secondary prevention, not primary. So if aspirin cannot be given due to some reason, you can give Clopidogrel. So depending upon any side effect, contraindications, one or other agents can be used. And other antiplatelet drug is the Dipyridamole. So sometimes what happens, you cannot give either aspirin or Clopidogrel, then Dipyridamole may be given to the patients who require antiplatelet agents. Various other agents or treatment modalities have been tried to help the patient with ischemic stroke, like expanding the intravascular volume, or giving vasodilators, or increasing the blood circulation to the brain by causing hypertension. All these treatment modalities have been tried, but they have not been proven to be better than no special treatment. So these neuroprotective agents have not been proven to be helpful to the patient with ischemic stroke. Supportive care, as I mentioned, beside the treatment of definitive treatment of the stroke, we should take care of all the associated condition of the patient. Patient may be having seizure, patient may have some malnutrition, patient may be having some hypovolemia, hypoxia, dysglycemia, all have to be taken care of. Okay, but there is no role of antibiotics prophylactically. If the patient has got some doubt about infection somewhere in the body, that has to be treated on merits. But only for stroke, there is no role of antibiotics. With this, I come to the conclusion of this discussion. I hope it must have helped you, and you should be all familiar with the stroke. As you will see, these patients not only here but at every place, and also in your exam, you are almost always likely to get a patient of stroke. So for your exam purpose, for your clinical skill, you should all be familiar with stroke, how to evaluate, how to make the diagnosis of ischemic stroke, what are the usual treatment modalities available for stroke, and which patients are candidates for ischemic stroke revascularization, medically or mechanically, what are the indications and contraindications for thrombolytic therapy. Thank you for watching. With this, I close the